Okay, there we go. So to speak with us today, we have Jessica Kasnick. Jessica is a registered dietitian working clinically for over 16 years in both inpatient and outpatient settings. Jessica started her research and career in adolescent eating disorders, receiving a National Research Award for the clinical practice guidelines she produced in 2005. Over the last 5 years, however, she has specialized in oncology, working with patients with gastrointestinal cancers at the Cross Cancer Institute in Edmonton, Alberta. While in her current role, she has been able to participate in and lead research, advocate and create change in nutrition care for these patients, and present at multiple oncology-based conferences. Currently, Jessica is a co-investigator on a study looking at patients with advanced pancreatic cancer with pancreatic exocrine insufficiency, with the hope of helping to support change in clinical nutrition care for this population of patients. Jessica loves the work she does and has a passion for helping to translate evidence-based clinical nutrition information and into actual daily patient care and practice. So with that, I'll let you take it away, Jessica, and you can let people know if you would rather take questions throughout or wait till the end. But the floor is yours.
Hey, hi everybody. I have to say that bio is about 5 years old. Sorry, everybody. I've been practicing 20 years, 9 of them in oncology. My bad. That one's quite out of date. Sorry. We've actually published the research in pancreatic exocrine insufficiency. There were some really interesting findings. So we'll go through some of that today. But yeah, that one's a little bit out of date. Let me just start sharing my screen and we'll get going in our talk. Hmm. Okay, does that look okay, Jessica?
Yes, it looks great from my end.
Perfect. Okay, so thank you everybody for joining us on this Saturday morning. I'm happy to be here with you guys. Like Jessica mentioned, I work at the Cross Cancer Institute in Edmonton, and I specialize in one of the main populations that takes up the majority of my work time is with pancreatic cancer patients. So I think today, as they approached me to talk through what would be most helpful for this series is to talk about nutrition and pancreatic cancer. So just a sec, I forgot to start my timer. Nutrition and pancreatic cancer, we'll talk about the different components that impact that, helping give you guys a really good sense of information, hopefully that can help you and your loved ones. Disclosures, I have none. There's no conflicts of interest or anything. So today I'll talk about the nutrition implications of pancreatic cancer on a patient and their digestion and whatnot. We'll talk about the identification and the diagnosis of pancreatic exocrine insufficiency. I think for patients and their families to be aware of this, to understand the signs and symptoms, to be able to advocate or work with their healthcare providers on this makes a huge difference. And that was a big piece that was found in the study that we did over that couple of years at the Cross Cancer. So we'll then look at the treatment of PEI. So pancreatic exocrine insufficiency, also known as PEI. I'll use that kind of short form acronym throughout the talk. So treatment of PEI will be pancreatic enzyme replacement therapy, or PERT, as I'll refer to. And then at the end, I'll go through nutrition strategies to help troubleshoot really common challenges that I see in this population when I'm working with these patients. I find it really helpful to take a step back a little bit and have everybody kind of understand some of the anatomy piece of things. So where your pancreas is, if there's a mass in my pancreas, what does that mean to my digestion? Because as you experience symptoms with this understanding, I find you guys are much better able to help figure out what might be from my digestion being altered, what might be from my treatment, what might, so it really helps to have the information, I find. And so on the right side, you see this is kind of the average human body. You can see your esophagus coming down your stomach. This little skinny organ behind here is your pancreas, tucked right behind your stomach here. And after your stomach, we go into this first part of your small intestine called the duodenum. And that's where all your digestive juices, like bile that comes down from the liver and everything from the pancreas, goes into this small intestine to help you digest, just for you guys to have a sense and awareness. And so you can see it in a little bit more detail. So your pancreas is this kind of long, skinny organ. Its tubing connects with the bile duct that comes down from your liver, as well as your pancreatic duct that puts your digestive juices and enzymes into your intestine for digestion. So I'm not going to spend a lot of this. It's not meant to be an anatomy lesson per se, but it helps you guys understand when you're experiencing certain symptoms or when your loved one is. It's so helpful if we can really identify what is from which concern so that we're addressing the intervention appropriately. So, pancreatic function, your pancreas has two very, very important functions. First being exocrine function, which is producing and secreting digestive enzymes and juices. So, you have three different pancreatic enzymes that your body makes. One is called protease to help you break down protein, amylase for carbohydrate, and lipase for fat. You also secrete water and bicarbonate from your pancreas, and that bicarbonate helps to neutralize your stomach acid. So the exocrine function of your pancreas is about like 95% of it. Then the endocrine function of your pancreas is the other big piece that it does. It's a small percentage of your pancreatic function, but it's the production of hormones like insulin and glucagon that help you regulate your body's blood sugars. And then other hormones like gastrin and amylin and things that help you regulate your digestive, like movement and your hunger and satiety, hunger and fullness. And so the pancreas has huge, huge, important functions when it comes to our nutrition and digestion. So when we're thinking about the impact then that pancreatic cancer might have on my nutrition or my digestion, 95% of pancreatic cancers diagnosed are an exocrine-based tumor, so pancreatic adenocarcinoma. There are other ones like a neuroendocrine pancreatic cancer. There's an Ansier cell. There's a couple other smaller, very much less common. But the majority of the pancreatic cancers we see diagnosed are these exocrine-based tumors, adenocarcinoma. So exocrine means it's originating from those exocrine tissues that are making your digestive enzymes and juices. And so you can see as we think our way through it how adenocarcinoma is likely going to impact how my pancreas is doing in terms of making and secreting my digestive enzymes and juices. So it's important when we're assessing a patient or as you're kind of thinking about things if it's discussed with you. So the location of the tumor will impact your digestion. So, a tumor at the head of the pancreas will have a greater impact on your pancreatic function for like secreting those enzymes because that's where all the tubing goes into your small intestine to do its job, right? And so I know if a patient's tumor is in the head, they're far more likely to have enzyme insufficiency versus if the tumor is at the tail. Even if the tumor is in the body of the pancreas, there's going to be a little less issues with their enzyme function than at the head. Um, when I am preparing to see a patient, I'm always reviewing the CT to know it'll talk about ductal dilation. So is that tubing in your pancreas a little bit blocked up and so it's bigger? And that tells me again, some of those enzymes your body is making might not be making it into the intestine for your digestion. So it's all these kind of pieces of the puzzle that help us understand where somebody might be at in terms of their digestion so that we can help correct it. So the other, there's a few different forms of treatment that we provide for patients. One kind of section of treatment can be surgical. There's a couple different surgeries that we'll see in our pancreatic patients. So one is called a Whipple surgery, and that's what this picture is showing you. So a classic Whipple removes kind of everything on the left side here. So that little C part of the small intestine called the duodenum, the head of the pancreas. If you have a gallbladder, the gallbladder is removed, and sometimes the kind of top of the stomach. And then everything is reattached to the small intestine. We can also see a total pancreatectomy, so the entire pancreas is removed. We can see a distal pancreatectomy, so just the tail of the pancreas is resected. Or sometimes we can see what's called a palliative bypass, and that's where the area of disease is bypassed and the stomach or the different organs are reattached like a Whipple, but the part of the pancreas that's affected can't get cut out safely. So it will stay in place. And so these are the different scenarios also where we can see if we're removing all of the pancreas, well, then you certainly are going to not have pancreatic enzyme function. Whipple, there'll be a significant compromise to the enzyme secretion and function because half of the pancreas was removed. So what is PEI, or pancreatic exocrine insufficiency? It's a condition where you're not producing enough, or the production of your enzymes are inappropriate in terms of their ability to get into the duodenum, or that small intestine section where it's needed to help you digest. So when somebody has PEI, it will be malabsorption, or like a poor secretion of all three of the enzymes. So sometimes, as pancreatic enzyme insufficiency is becoming more well known, and we're working really hard for everybody, certainly across Canada and more, to be aware of it and to intervene and to treat it. What happens is the original form of the medication is all hinged off of dosing off of lipase, the one enzyme that helps with fat. And so sometimes there's a bit of a misconception that we only need it for lipase, or that it's only an issue with the lipase. But the reality is, if you have PEI, you are having it for all three of those: protease, amylase, and lipase. We also feel that it's reflective that you then probably aren't secreting enough bicarbonate also. And so that kind of all comes together to affect your ability to absorb the three main macronutrients your body needs: fat, protein, and carbohydrate, because those enzymes are not secreting at the right amount, or the timing is altered. But that's what PEI is. And so prevalence: 90 to 100% of locally advanced or metastatic pancreatic cancer patients are going to have PEI. We know that, like I said in the last slide, there's an increased risk based on the location and the size of the tumor. The other information we see in the CT scan in terms of the rest of the pancreas, how that tissue looks, if the duct is dilated, that helps us assess the degree. But 90 to 100%, like really the majority of patients. Then post-operatively, so patients that did undergo a surgery, 80 to 90% of Whipple patients will have PEI. Distal pancreatectomy, 20 to 50%. Total pancreatectomy, 100%, as we said, right? We know if we're leaving PEI untreated, then there's a significant impact on quality of life. And that was a piece of the study that we did. We did look at kind of how many of the patients required enzymes, what dosing range did they hit therapeutic results at. Throughout all of the intervals that we reassessed our patients over a 6-month period, we also had them fill out a quality of life and symptom report. And it was a very clear finding that patients that required enzymes, when we got them to their therapeutic dosing, marked improvement in quality of life. And so we also know that if PEI is not addressed, then your nutrition status will be profoundly affected because you're not able to absorb your macronutrients. We know it can impact postoperative survival and overall outcomes if you're not able to absorb the nutrition that you need, or the person going through this. So symptoms of PEI. There's multiple symptoms. We don't wait for somebody to have all of these symptoms. You don't need to have all of them. We look at, is something happening in your pancreas? Does somebody have a pancreatic mass of some kind, or pancreatic adenocarcinoma? And really any one of these symptoms, because we know the prevalence is so high. So either way, most common symptoms that I see is strong smelling gas, foul gas, and bloating, especially in this pattern where it builds as the day goes on. So often patients will tell me that they feel pretty good in the morning, and then as soon as they start eating throughout the day, they start to feel a sense of gas and bloating. They'll talk about kind of embarrassment or discomfort with a really strong smell that's not typical. Um, some will have diarrhea, or what we call in the medical world steatorrhea, which is like pale, fluffy, floaty stools with some urgency, and sometimes an oily residue on the water or on the toilet bowl. And so sometimes between diagnosis and surgery and chemo and treatment and all these different factors, we can't always assess color of stool. But I will say there's not a lot of situations that cause your stool to be pale other than malabsorption. And the oily residue is another really common one. So chemo will never cause somebody to have an oily bowel movement. The only reason for an oily bowel movement is I did not break down fat properly to absorb it into my body. And so there's a couple clues there that no matter what other things are happening for a person, we know this is really PEI versus something else. Urgency can be a factor for patients. Burping or heartburn and reflux GERD-like symptoms. The burping I find patients will describe as quite powerful burping, almost like carbonated, even though they haven't had something carbonated. Cramping and abdominal pain with digestion or after eating. Gurgling. So the belly's kind of gurgling away as you digest. That's another really, really common one. From a blood sugar perspective, a lot of patients, not everybody, but a lot of patients with pancreatic cancer may already have diabetes. And so sometimes what will happen is I'll have patients be like, yeah, I don't know, but I've been able to reduce my insulin dosing significantly. And sometimes that's actually about the fact that part of what you're eating is not actually absorbing. So you're not requiring as much insulin to manage that impact. So a decrease in insulin is a bit of a clue for me. Sometimes we see that just with weight loss that's happening, but that is a clue for me for sure. And hypoglycemia. So all of a sudden, a patient with diabetes starting to struggle with hypoglycemia when that wasn't typical. So a low blood sugar. And that's happening, same thing. I'm malabsorbing. So even though I'm eating, I don't understand why I'm running low. It may be that you're not absorbing what you're eating. Another one, unexplained weight loss. So sometimes in this situation, we understand why somebody's losing weight because you're having pain or discomfort or lack of appetite. There's all these factors, right? And so sometimes somebody's losing weight and we know why. But some patients that I work with, they'll be like, I am so hungry. Like I am eating. I'm eating and eating. And the spouse or their loved ones are like, yeah, like they're eating better than me. And we can't they find it unexplainable why they're still losing weight. Again, that's a clue. Okay, it was part of what you're eating not actually absorbing for you to be able to maintain your weight. So muscle loss, and especially in the arms and the legs, can be another sign. Weakness and fatigue. Food avoidance. So some patients will say to me like, oh, well, with all this going on, there's just, as long as I'm really careful and I avoid the foods I can't digest anymore, I'm okay. And so what I've come to learn is you often patients start avoiding things because things that are higher in fat or things that are higher in protein, like energy dense foods, really need enzymes to break down properly. And when you do not make enough enzymes and you consume those foods, you really don't feel well at all. Like it's, the urgency in your bowel or the cramping or the discomfort with digestion, there's a bunch of those symptoms present. And so a lot of the time, by the time you're meeting with the medical team, you've started avoiding a whole bunch of foods that would trigger it. And the reality is, patients with PEI shouldn't need to really avoid anything. You can eat a full range of nutrition. You just need to make sure that when you're eating, you're taking the enzymes that your body requires. And as we go through the talk, I'll help make sure that that's better understood for everybody. Then the last thing that we'll see is vitamin deficiency in your fat soluble vitamins. So vitamin A, D, K, E, those vitamins, we'll see issues with that because if I'm not able to break down fat far enough for me to absorb it into my body, then the vitamins that are called fat soluble vitamins are not also able to transfer into the body for function. So we'll see some vitamin deficiencies as well. So the thing that I think partly is why I've always found this area just so interesting is though the pancreas has such a huge role nutritionally, and though when we alter it with a disease, it has such a grave impact, there's actually something we can do about it. And it works very well when we're doing it well. And that's where Craig's cause, doing these talks for people to have the kind of power of information and knowledge is so important, because then you guys can be your best advocates, and then we can work behind the scenes to kind of spread the word across Canada for clinicians and teams and stuff like that. So the main intervention for PEI is, like I said at the beginning, PERT, Pancreatic Enzyme Replacement Therapy, is indicated if somebody has PEI. Pancreatic enzymes are prescribed by a doctor with or without the help of a specialized dietitian. The exact dosing, it's not well established. So for a long time, many years, we were using the dosing that was for patients with a condition called cystic fibrosis, so a very, very different disease. And we kind of extrapolated from that and applied it to pancreatic patients. And we know that likely a pancreatic patient requires more than a cystic fibrosis patient. In the last 2 years, some stuff has started being published specifically for pancreatic cancer patients where there's some entry dosing suggested. But ultimately, we try to look at the individual patient, what specific symptoms you are experiencing so that you understand that. We initiate the enzyme therapy and then we adjust and titrate till we resolve the symptoms you're experiencing. Pancreatic enzymes that are commonly used. There's two big brands in Canada, two main ones, Creon and Codazyme. For Creon, there's three different strengths, 10, 25, and 35. For Codazyme ECS, there's 8 and 20. The ones that I have listed here are a kind called enterically coated. So they have a special coating for your stomach acid so that they don't just denature when they get to your stomach. And that's a really important piece because when I was starting out in my area, when enzymes really weren't well established, Codazyme has a non-enteric version that was getting prescribed all the time. And if you have a stomach and you have then stomach acid production, you need these enterically coated versions. If they give you the non-enteric, they don't work. So if somebody's put on Codazyme 10,000 and they have a stomach, they're going to find their enzymes are not working well, and it's just because your stomach acid's denaturing them. Each pancreatic enzyme pill is a combination of all three of the lipase, protease, and amylase. So it's not that somebody's taking one for their lipase, one for their protease. Each pill is a combination of all three of those pancreatic enzymes, helping you to digest. This chart, in no way do you need to really look closely at this or memorize anything. It was more just for patients to have a sense of Creon 10 is almost, I'll show you at the point. So Creon 10 is almost identical in its dosing to Codazyme ECS 8. So they're really a direct comparison product, just two different brands. Creon 25 is a direct substitution or equivalent to Codazyme ECS 20. So those are the kind of two main ones that we see used a lot. And like I described, this Codazyme, which accidentally gets prescribed often down here, is a similar dosing to Creon 10s, but like I said, it's not coded for the stomach and shouldn't be used if you have a stomach. So, treatment of PEI with PERT. PERT is needed with solids and liquid food. So, a lot of the times I'll hear a misconception from my patients that, oh, well, with my shakes or with a glass of milk or with those kinds of things, soup, if it's not really hard and crunchy, I don't need it. And I completely understand because we use the wording, it helps with digestion. I think a lot of times patients think of it as a texture thing. So, a really crunchy, dense food requires more enzyme than a soft or a liquid does. And it's not that. The enzymes are actually breaking down the chain of lipids or fat in your food to individual molecules for absorption, or breaking down the chain of protein to individual amino acids that your body absorbs. So it's not texture based. And so if you are having liquids that have protein and fat, or soups and things with a complex carbohydrate like pasta noodles or potato or things like that, then they also require pancreatic enzymes for digestion. You need them in general. If you need them at your meals, you need them at your snacks. And usually you need about, half as much at a snack as you do at a meal. But again, it depends on the size, right? If somebody's having small, frequent meal/snacks and they're all about the same size, then your dosing will probably be similar. You don't need pancreatic enzymes with simple sugars or simple carbohydrates like a popsicle, hard candy, fruit juice, pops, things like that. So simple sugars on their own do not require pancreatic enzymes, or things like black coffee, black tea, or coffee with just sugar or honey, or tea with just sugar or honey, so no milkiness to it, then you do not require an enzyme. Slightly higher doses are needed if the meal is or the snack is much higher in fat. And so if I'm having a creamy pasta, if I'm having a beef-based item versus a chicken-based item where the meat is a bit denser in fat and protein. So higher fat or protein requires more enzyme or a larger serving. So more food needs more enzyme to break down. And that's why our meals usually need more than our snacks. And for lots of my patients, they have kind of one meal a day, most often supper. That's a bit bigger, more generous. It has more protein to it because there's a more substantial meat of some kind. And in that case, maybe their supper meal needs more enzymes than their breakfast and their lunch. And so that's something that as you're working with, whether it's your dietitian or the healthcare team, you're kind of troubleshooting. And that's why I think when patients understand why they're having enzyme insufficiency, what's going on, what their specific symptoms are, where my dosing is going to start, then you guys become your best advocates to be able to be like, oh, you know what? We're heading out for dinner tonight. Usually when I eat out at a restaurant, it's best if I just dose my enzymes up because more often than not, restaurant food is a little bit denser in fats or calories. So play it on the safe side and dose my enzymes up. Oh, tonight my wife made my absolute favorite. I'm feeling good today. I'm gonna have more than usual. Take an extra enzyme. Like I just kind of said in my spiel there, I really feel patients need education when they're initiating enzymes so that you guys are in the driver's seat in terms of how best to navigate this. I always have patients, so I'll recommend a prescription range. The most common for the average patient that I work with, adult, female versus female or male, um, it will be kind of Creon or Codazyme ECS 20 or 20 Creon 25 or ECS 20, and 2 to 4 capsules at meals and 1 to 2 capsules at snacks. I'd say most patients fall in that range. There's absolutely some patients that require above 4, but the research that I mentioned in the last 2 years that have come out helping us to guide our starting prescription for pancreatic cancer patients, it's 40 to 50,000 units as a starting point. So that would be equivalent to 2 of Creon 25 or ECS 20. Usually, if I suggest that prescription of 2 to 4, I have the patient spend the first couple of days taking 1 capsule with each. So just start out, be aware of what your specific symptoms are that we've discussed, be it gas and bloating building throughout the day, cramping or pain, whatever specific symptoms are yours. We start with the enzymes just 1 at each meal and snack, and we observe for the improvement of the symptoms. I don't expect 1 capsule at each to resolve the symptoms for many people, but as we start slowly like that, it gives you time to kind of avoid, if you pick up your Creon or your Codazyme prescription, they'll talk about side effects. And sometimes the side effects will say bloating, cramping, fullness, nausea, as I have that listed there, right? And so some patients, and even when I started in the area, the docs would be like, listen, you're going to feel worse before you feel better. And what I found was if we start you guys low and slow and just have you gradually bring it up, you start to gradually feel an improvement in your symptoms. We end up hopefully not getting you on a dose higher than you need, just reducing risk of kind of pill burden, because I know a lot of patients are already dealing with taking so many more medications than usual. So I usually have you start low and slow. We observe your symptoms and we adjust. Spend the first couple days taking just kind of 1 at everything. The other important piece of why I do that is one of the main side effects of the enzymes is you produce a significantly more amount of stool. And so when I start working with somebody, a fair bit of patients are struggling already with some constipation. So at onset of enzymes, I'm making sure that we have a game plan of clearing current constipation, or making sure if somebody's not constipated that as we start these enzymes, your bowels are moving sufficiently so that as you start them, you don't end up getting backed up and then feeling bloating and cramping and fullness, not from enzyme insufficiency, but actually from your bowel being full. And that's an important piece because I've had some patients when they didn't really realize up their enzymes and up their enzymes. And in a 2-week period before I could follow up, they're taking 6 or 7 with their meals. And it was just actually that they started to get their bowel full. Then it felt like bloating, cramping, and gas. And then they took more enzymes and more enzymes. So that's why start low and slow, make sure your bowels are moving well. So I usually say to patients, your bowels, it regardless of your lifetime history of bowel movements, when you initiate enzyme therapy, your bowels should be moving at least once or twice a day, and it should be a large amount of soft stool. If that's not happening, then we need to troubleshoot. Evaluating response should be routine. And so for me, when I initiate enzymes with a patient, I try to follow up with them kind of at 2 weeks. And then I follow every couple of weeks until they feel comfortable and established. And then it just, the frequency of follow depends on what your needs are. And so now with organizations like Craig's Cause and some of the individual producers like Creon and them have educational videos and information. So if some of you are living in areas where you don't maybe have a dietitian or a team following as closely, there's so much more happening online now for you guys to provide you with some supports on how to navigate titration and adjusting your dose and being aware of those things. And then a big one is once you initiate enzyme therapy, there's no indication for fat restriction. There's no correlation with fat consumption and pancreatic cancer. It's understandable that for a period of time, somebody with this starting would feel unwell when they consumed fat. And that's again from a PEI perspective. But the moment we intervene with enzyme therapy, you should be able to eat whatever you want. So if patients feel that the enzymes aren't working well, I find, and that was something when I first started in the area, lots of patients were like, or the docs were like, I don't find they work very well. I don't see good results from them. I think it's usually that that's not being used properly or it's a lack of understanding. And so first things first, if somebody initiates their enzymes and they come back saying like, oh, it's just really not working well for me, always, of course, make sure they're on the right formulation. So make sure if they have a stomach that they're on an enterically coated enzyme. Then the next thing I look at right away is timing. At what point when you're eating are you taking those enzymes? If you're taking them at the end of the meal, they're usually not effective. So are you taking it right at the onset of your meal? So meal or snacks in front of you, you are about to begin, take your enzyme dose and go. That's my most common recommendation for patients. Yeah, the enzymes work for about 1 hour. So let's say you take your enzymes, you're about to start, your phone rings, or somebody asks you to come help them with something. Know that your enzyme dose works for about 1 hour. If you're having kind of like a prolonged meal or something special in any way, then you may want to spread dosing out like an appetizer and a break, things like that. But for the most part, enzymes taken right prior to starting or right at the onset, I find to be far more effective. Frequency. So the other thing I'll see when a patient's like they're just not really working is I'll also ask, oh, do you find you ever forget to take them? And it's not meant in a shame way in any, but sometimes what I'll find is they're like, oh, yeah. I'm like, oh, how often do you forget? They're like, well, usually once at least every day. Well, as soon as you've consumed a meal or a snack that required enzyme, you're going to have some of those symptoms until those maldigested foods leave your body. So for some people, it depends how frequently your bowel is moving, but it might be for the rest of that day. And so timing is often a culprit if it's not timed well when you take your enzymes, or frequency, making sure they're being taken with everything that they're required. And it just helps us understand if you're struggling to establish a new pattern and remember to take them all the time. I hear that all the time, and I really understand that. I think anybody would struggle with that, but it just helps us know it's not that they're not working. It's probably just that that little bit each day you consume without them has an impact. Then if patients are finding them affected, so I'll have patients that are doing really well on them for quite a while. We have an established kind of dose range. They know what they're doing. Then all of a sudden they're like, gosh, they're just like very symptomatic again. If they're not taking a medication category called a PPI, a protein a proton pump inhibitor. So things like pantoprazole. It's typically a category of medication used for heartburn or GERD. Then what we need to do is layer the PPI back in that medication. And it's because early in the talk, I talked about how your pancreas makes bicarbonate, and that neutralizes your stomach acid. If that part of your pancreatic function is really diminished enough, then your stomach acid is denaturing these enzymes you're taking. So I'm taking my Creon, I'm expecting it to help me digest, but if my stomach acid is not being neutralized, it's denaturing my enzymes. And so what we'll see is a patient will go along there, they're doing really well on their enzyme dose and it stops working for them, or they increase their dose. And so if I have a patient coming to me and based on what they're eating and their dose, it just doesn't make sense. They're on a really high dose. We'll layer a medication like Pantoloc or lansoprazole, anything in that PPI family in, and that usually makes the enzymes work better. It allows them to sometimes bring their dose of enzyme down a little bit, and the function of the enzyme returns back up to what we had expected before. So the other thing we'll see sometimes as I'm going along, I have somebody established well on their enzymes, things with digestion is good. I've troubleshooted that there's not an issue with needing to layer in a PPI medication, but they're losing weight again. And sometimes for patients that can be pretty scary. And so one thing that's really important is that you're monitoring your blood sugars. So at least at our cancer center, if somebody's in treatment, we're drawing their blood sugars randomly when they come in for their blood work before each chemotherapy. And so it gives us a little snapshot each time we're checking their blood to make sure there's no kind of significant abnormalities. But if you are somebody that has diabetes, it's important while you're in treatment to monitor your blood sugars, because one, just the disease itself being in your pancreas, your pancreatic function of your endocrine function of that insulin and stuff, that can diminish as time goes on. A lot of the cancer treatments can impact your blood sugar control. So one of the most famous, one of the main chemotherapies for pancreatic cancer is called FOLFIRINOX, and it can really elevate a patient's blood sugars. It's prescribed with a steroid, dexamethasone, taken day 1, 2, and 3. And that causes anybody, diabetes or not, to have an elevated blood sugar. And then FOLFIRINOX itself, the chemotherapy agents, are infused with dextrose. So there's like 2 reasons that a person's blood sugars could really become elevated when they're on FOLFIRINOX. And so it's important that you're monitoring your blood sugars, because if those aren't well managed, then you may experience weight loss just from hyperglycemia or a high blood sugar. So we're like scrambling and adjusting enzymes and doing all of these other things when it may just be blood sugar related. So then as we shift into your nutritional requirements, so when somebody has cancer, whether they're in treatment or not, you have an elevated requirement. Specifically, the main nutrient we focus on is protein. So again, I won't go through too many details here, but the average person, a dietitian, or we would calculate their protein requirements as 0.8 to 1 gram per kilogram of body weight a day. Whereas in this population, we're looking at kind of 1.2 to 2 grams per kilogram per day of protein. You have increased calorie requirements, partly related to the disease itself. Also, if you've experienced weight loss as stuff was coming on before your enzyme insufficiency was diagnosed and whatnot. So partly you're on an elevated caloric requirement and protein requirement to recuperate weight loss, to prevent further ongoing muscle and weight loss, and to do with an increase in your metabolism from the disease itself. We do not restrict fat. To be honest, I use good quality fats as a tool to help get more calories into patients. So top priority in my perspective, of course, once we figure out how to get you guys absorbing and digesting properly is putting you on an elevated protein diet. But then when we're still battling trying to get enough calories in to avoid weight loss in any way, I use good quality fats a lot. And I do that more than using carbohydrates or sugars, because then really commonly a lot of pancreatic patients are dealing with diabetes or at risk of it coming on or worsening. And so I'm not pushing calories from sugar sources. I'm pushing it more from protein and fat, which won't alter your blood sugars. There's nothing wrong with having carbohydrates, of course not. But it's a focus, like a perception that you guys can't have fat is common. Lots of patients come to me, or even if you've had the surgery where your gallbladder's removed, there's like an old school thought process that then you'd follow a low fat diet, and that's not the case anymore. We talked about it a little bit already. It's important, if you have diabetes, that you manage that diabetes. A lot of patients over the years will say to me, oh, well, my family doc said with this now going on, my diabetes really isn't a focus. And that's fair. We're thinking our way through what's most prevalent and what's most kind of acute for me. But the reality is, if you are wanting to undergo cancer treatment, we have to manage your diabetes. If we don't manage your diabetes, then you'll have all sorts of side effects from the diabetes that impact your ability to have treatment. And then the other piece is just, if somebody feels up to it, and they're not overwhelmed by all the bits and pieces of their treatment as is, then we can look at things like supplementing with a multivitamin that is safe. A general women or men's multivitamin is safe during chemotherapy or treatment. Vitamin D is another one, fish oil. And depending on where your iron and anemia status is, we might recommend supplementing that. So I won't go through too much detail of this, but like I said, a lot of patients with PEI can have malabsorption of their fat-soluble vitamins. So sometimes ensuring that somebody has a multivitamin. Also, if I'm having a patient really hone in their diet on protein and fat, then sometimes fruits and vegetables, though they bring so much value to us, they become less important when I'm just trying to hold your muscle and maintain your body in the context of cancer. And so maybe if you're not having as much fruits and vegetables because you're filling yourself with your protein and other items, a multivitamin can ensure you don't have any micronutrient deficiencies. The one thing too is, sometimes with a multivitamin, patients feel overwhelmed by how many pills and medications they're taking. You don't need to take it every single day. You could be taking it, I don't know, 3 times, or you take it the second week of your cycle when you're off of treatment and you feel a little bit better. You're not feeling as fatigued and as burdened by everything. So multivitamins are not all or nothing, but they can bring some value. Vitamin D specifically, there's some literature in cancer populations where it can help you maintain or increase your lean body mass, so your muscle mass. It can help with improvements in your immune function and things like that. There's also correlation with omega-3 fatty acids, helping with appetite in cancer patients, helping with muscle mass retention and avoidance of loss, and improving your body weight and things like that. So those are kind of some key ones that I thought are worth highlighting for you guys. Common barriers to good nutrition that I see in the patients that I'm working with will be poor appetite, pain and indigestion with eating and drinking, early or prolonged satiety. So feeling full really easily and for a long time considering what you ate. So patients will say, I barely had anything and then I was full all day. Constipation or diarrhea, and taste changes. I would say when I thought my way through what I see most commonly in my patients, this is the grouping. So poor appetite, as with anything, it's going to be multifactorial. And what I mean by that, there's lots of things that come together to put somebody in a place of poor appetite. So some of the appetite could be disease related. It could be related to treatment side effects, constipation, or physical changes. So the first thing I'm doing when somebody says that they have poor appetite is not actually blaming it on the cancer or the treatment. First things first, I assess for constipation because more often than not, it's that. More often than not, patients are battling with constipation, which completely alters their appetite or desire to eat. So assess for constipation, clear and manage constipation if it's present. Then manage any treatment related side effects, of course. So a lot of patients will describe not nausea, but even their loved one asking what they feel like, or while their loved one is cooking. So looking at the plate of food, even the idea of food, they're like, no. So they'll say to me, no, I don't have nausea. And then when I ask that question, they're like, oh, yeah, for at least a few days each treatment cycle, or for the first week, I don't even want to think or look at food. And really that is on the nausea spectrum. So nausea has a spectrum, one end being I'm literally throwing up, I'm so nauseous, but the other end is I don't even want to think or talk about food. So a lot of you who have nausea medication prescribed for nausea as needed, it will respond to that poor appetite part that doesn't even want to look, smell, or taste food. So just for you to be aware of, we can use your nausea medication those days from treatment where you just can't even think about it. But as an example, if you initiate that, but you're still super constipated, it's not going to help that much to perk your appetite up. So we kind of assess for constipation, clear it, then look at any potential treatment side effects like loss of appetite or desire to eat, use our nausea or medications to treat that. The main medication, at least in my world, and I think it's pretty consistent across Canada for sure, is a medication for nausea as needed is called metoclopramide. It's also known as Metonia or Maxaran, has three different names, and it is one of the main nausea medications prescribed. And it can also help the movement of food through your digestive tract. It's called a prokinetic as well as a nausea medication. And so by helping things move through your system a bit more quickly, you don't feel as full as easily or for as long. And so it's very helpful at perking up appetite. Sometimes for poor appetite, I use something called mechanical eating. So, unfortunately, eating shifts to something that you need similar to another medication. Your body requires the nutrition, and we eat based on the clock or eat based on knowing we need to versus waiting for us to feel like it. Small frequent meals is I think one that's pretty obvious to a lot of people, but small frequent meals that are really nice and nutrient dense can be really helpful for patients. So they're not needing to sit in front of 2 or 3 really big plates of food, but smaller bouts spread out throughout the day. Focus on best times of day. So if your appetite is better at one time versus another, try to have your larger meal there. And the other strategy I use with a lot of my patients is something called, I call it 3 big sips, but picking a liquid that has a good amount of protein or nutrition. So whether it's a protein shake or an Ensure or Boost, something like that, or whether it's that high protein milk we have at grocery stores now, at the end of every meal and snack, when you normally would have stopped eating, you just tell yourself 3 big sips. You take 3 big swallows of your nutritional drink, whichever one we've selected or you've selected, and as the day progresses, you get that little bit more nutrition in over and over and over, which allows us to increase your intake, but also it stretches the stomach a little bit. It's kind of like physio for your stomach. As you're not eating well, even up into for three days to a week, the stomach will shrink up a little bit. So if we can kind of gradually stretch the stomach back out using liquids, it usually doesn't cause too much discomfort for the patient because it's a liquid that'll move through there pretty quickly, but it puts a little pressure on the stomach to help with that refeeding. Pain and indigestion. So a big part of pain in this population with eating will be PEI, that exocrine or enzyme insufficiency. It's the most common cause. The next one that I see is constipation. So if somebody is describing, or if you are feeling you have pancreatic cancer and you're feeling pain and indigestion when you're trying to eat, make sure you're assessed for PEI and make sure you're assessing for constipation. Clearing that constipation. The other third kind of thing that can be going on is needing that medication category that I talked about called a PPI or a proton pump inhibitor. A lot of patients, when this disease was coming on, they were initially worked up for reflux and they were initially put onto Pantoloc or pantoprazole because the family doc or people were thinking they may have had heartburn-like symptoms. But then when that medication didn't resolve it and further investigations found what was going on, a lot of patients will stop taking that pantoprazole because they're like, well, now that we know it's not heartburn, and really because of that bicarbonate dysfunction that happens, you often benefit from that category of medication. Um, But yeah, just another one of you don't need to restrict foods. Um, Early and prolonged satiety, feeling full easily and for a lot of hours. Again, like everything for you guys, it's multifactorial. So constipation is the most common cause that I see. And really big picture, that's a lot easier to treat than disease-related loss of appetite or treatment-related. And so first things first, clear your constipation, make sure your bowels are moving. Next, make sure we've assessed for PEI and intervene appropriately. Understand that your stomach may have shrunk up during this period and using those strategies like 3 big sips or mechanical eating to push yourself to refeed. Using that medication that I mentioned, metoclopramide, to help with the motility of your digestive tract to help you refeed. And then another thing that can happen is dysmotility. So in those first couple slides, when I showed you where your stomach is and your pancreas is kind of tucked right behind, sometimes the pancreas mass can push on the stomach a little bit and things don't empty out of the stomach as quickly. And so there's different strategies we use if that's what's going on. So if you aren't constipated, we've treated your PEI, you're doing all those things, but you get this really bad bloating up high in your stomach, then it can be that we have to watch skins and seeds and certain fibers. So, like I said, we'll go through and use those strategies, constipation clearing, PERT for your PEI, mechanical eating and 3 big sips, using medications and things like that to help you be able to nourish yourself better. Then constipation is really common. A lot of patients are on medications that can be constipating, whether it's pain medication or one of the main nausea medications called Zofran or ondansetron. It is very constipating. And so we always want to look at things like your hydration status, if there's medications that are putting you at risk, because no matter how hydrated you are and how much roughage you're eating, if you're on a constipating medication, it doesn't matter who you are, you're probably going to need something to keep your bowels moving. And so I usually always set a goal with patients, like I had said earlier on, that you move your bowels every day. Soft, easy to move stools. And then we always, of course, for many reasons, ensure that you guys are hydrating well. Diarrhea, again, multifactorial, as with anything. With a pancreatic patient, I'm first, of course, assessing for PEI because that can cause that. And if somebody is having enzyme insufficiency and they are trying to use Imodium or the prescribed loperamide from the doctor to treat it, if it's enzyme insufficiency diarrhea, Imodium doesn't work. And so if somebody's trying to treat that diarrhea and they're taking Imodium and it's not helping, that's what's going on, and we need to address the PEI. So we're doing things like always first checking for constipation. Sometimes with severe constipation, we can get a type of diarrhea called overflow or bypass. So if you were constipated and then without clearing anything, just all of a sudden started having diarrhea, it's not actually real diarrhea. It's something called bypass or overflow. And we treat that very differently. Intervention, if you're having real treatment related genuine diarrhea, then we want to make sure you're rehydrating yourself, one with just enough fluid, but also using oral rehydration solutions like Hydrolyte or Pedialyte or things like liquids that have electrolytes. Taste changes are very common, but they're not common for what we think. So a lot of patients associate either the disease or chemotherapy or cancer treatments causing taste changes, and they can, but not as often as you think. Usually, if somebody says they're struggling with taste, I assess for thrush first, because a lot of the time it's thrush. And thrush is kind of a fungal infection in the mouth. All of us have thrush bacteria in our mouth all the time. But when we have a situation that reduces our immune function, the thrush can flourish. So when I have somebody in cancer treatment where their immune function dips down, then thrush has an opportunity to grow. So it's not about somebody not taking care of their mouth or something, we all actually have that bacteria in our mouth. It's just a matter of your immune system and kind of that perfect storm to create it. Thrush will come with either a loss of taste or a foul taste or a strange taste with foods. Foods don't taste like they should, a thick white coating on the tongue or on your cheeks, a sense of food almost sticking in your throat or struggling to take you're kind of like, I don't know, like I'm just stuff is sticking, and kind of an increase in kind of a slimy feeling in your mouth, sometimes white at the corner of your mouth and stuff like that. So same thing, if thrush is what's going on, there's not anything I can do to suggest how to fix your taste change other than to treat the thrush. Sometimes some of the chemotherapy, especially the FOLFIRINOX regime, you can get mucositis, so an inflammation and irritation in the lining of the mouth or on the gums. And that's where it's some of the suggestions here below. So using a gentle toothbrush, we can prescribe a mouthwash that people swish and gargle with. If things are tasting metallic, we use wood or different plastic cutlery, avoid cooking on metallic things. There's all sorts of suggestions for those styles of taste changes if you go to the Canadian Cancer Society website. And also just speaking with your healthcare team to kind of troubleshoot stuff. So I tried to push my way through stuff pretty quickly here. At the end, I'm open now for any questions that people might have. But we don't know. We don't know. There's not enough evidence on the specific impact of these enzymes. And so it's really interesting in that as we were doing the study at our hospital for a couple of years, that question comes up. And when I present to clinicians, like all the time, this question comes up and we don't know. It's the same with I've contacted the companies that produce these enzymes to ask them exactly how the timing works. Because if you get the information sheet from them about how to take them, it'll say take them beginning, partway, and at the end. And I know in 9 years of doing this, at the end does not work. I've almost never met anybody where it works at the end. And when I contacted the company, one, to ask about the stool, and two, to ask about the timing of function of the enzyme, the evidence doesn't exist. Their research department does not have a study to tell us the why. So all I go based on is clinical practice. And unequivocally, I've just never had a patient say they didn't notice an increase in their stool. And so I don't know if it has to do with because things further break down, there's like a different fermentation, or I'm not sure. But regardless, kind of consistently, patients describe to me almost a sense of being caught off guard. And that's now what I come to look for and expect from them when they describe it to me. So, I think, my understanding of it is very like people will have varying degrees of their own intrinsic function ongoing, right? And so obviously a total pancreatectomy won't. But if you're saying if somebody is on their pancreatic enzymes and they're on a dose that they think is reasonable, but still having that thing called steatorrhea or an oily residue, I would have them increase the dose. And then let's say you feel or your team feels you're on a large enough dose and it's not working well, then I would reassess for whether we should layer in that medication called a PPI to make the enzymes work better. Because somebody should not still be having steatorrhea or oily stools if we're dosing the enzymes appropriately. PPI is a category of medications called proton pump inhibitors, and they reduce gastric acid. And so what can happen is your enzymes won't work as well because your pancreas also isn't secreting bicarbonate enough. And then your enzymes that you're taking, those creons, get denatured and don't work. And so if somebody is on creon and still having an oily bowel movement, they either need to increase the dose, make sure they're taking them properly, and taking them consistently. So timing of dose when you take them related to when you eat. Is the dose adequate? And then plus or minus whether you need to add pantoprazole, also called Pantaloc, to help your enzymes work better and not get denatured by your stomach acid. But there's not in any of my, like, as I go through all this in our research, I don't have an association that somebody even on enzymes should still have steatorrhea. It's true that bile that's made in your liver, secreted by your gallbladder, and lipase, those two things produced in my body break down fat in my diet. But let's say I don't have functioning bile, either I've had my gallbladder removed or my liver is not secreting the bile quite right postoperatively. There's a bunch of situations, but that should not, we should be able to replace that by adding more lipase to ensure somebody doesn't have an oily bowel.
Okay.
So
Okay.
I haven't had a patient continue to have that oily bowel despite really getting their enzymes corrected.
Can
You
you
like
just,
what I find works for most patients, the most common is food's in front of you, you're about to begin, take the enzymes and go immediately.
yeah, that's
Some,
what I do. Yeah.
yeah, yeah, yeah. And so there, there's, like I would work my way through things. The upper end dose for a patient for pancreatic enzymes is quite large. So your body weight in kilograms, so let's say somebody weighs 60 kilograms, which is 132 pounds. So I have a 60-kilogram patient. Their upper limit of enzymes, if they were on Creon 25, is 24 pills a day. And so you'll see patients prescribe 2 to 4 capsules quite often, or like 3 capsules or 4 capsules with meals. But I absolutely have some patients where, based on their body weight, if they're 70 kilos or 75, some patients needing 6, 7, or 8 capsules with each meal. So, one, is the person taking enough? Two, are they working properly? So if I'm getting into 6 or 7 or 8 capsules, if they're not on Pantalog or a PPI, I would layer it in. Always, always making sure that my bowels are moving adequately. Because if, as I take my enzymes and I treat my malabsorption, I start filling with stool, then all sorts of symptoms present, whether it's gas bloating or maybe this oily stool that's passing by. There's all these different factors. And so make sure the bowel is moving enough. Are you taking enough? Are you taking it at the right time? Do we need to layer in pantoprazole to make them work better? Sure. So it's I can't say 100% without like knowing his full file, but I can say so. Sucralfate or sulcrate is the other word for that medication, is prescribed often when we think there's inflammation or an ulcer or irritation in the lining of the digestive tract. So I work with that medication a lot. Not as much in pancreatic patients, but it's not unreasonable. So if a patient, when they were scoped, or when a procedure that's common for pancreatic patients called an ERCP is done, when they're having biliary stenting or things like that, they may find ulceration and prescribe the sucralfate to help heal that ulceration. But the need for it ongoing, if you don't have an active ulcer or active ulceration, you should be able to come off of that. So I would look, depends. Sometimes post-operatively, if, oh no, he was not a surgical case. Yeah. So I think there's a chance somebody doesn't need sulcrate forever or sucralfate forever. The question of, would he still need his pantoprazole or not? So for the most part, when I have had patients, the question of, he has 70% of his pancreatic function, I don't know how we would know that. There's not actually a blood test or a test that we have that actually tells us how much enzyme his pancreas is still secreting. So I would go based on his symptoms. If you felt that the over-the-counter enzymes were working, fair enough. I haven't seen that a lot because we can't really control the function of the over-the-counter ones in terms of the ones that are in Creon and coenzyme are in different concentrations that mimic the secretion from the pancreas. And the ones done by over the counter are not just, they're just not formulated the same. The ones that are in Creon and coenzyme are porcine based, and they mimic more of how a human pancreas secretes. And so they seem to work better. But it's one of those, if I ever had somebody come to me and they're on their own enzymes that they're purchasing and they're working, well, I'm not going to tell you not to do it, but if you're questioning if it's working well enough, like the question that would come to my mind is, if the patient doesn't have a history of an ulcer they're really trying to heal up with, but they're still needing sucralfate, PPI, and these over the counter, I might pull back on the over the counter in case those enzymes are actually irritating his gut, and whether some of the irritation that's ongoing is just the need for adequate enzyme therapy. So I might pull back on the over the counter, initiate the prescription based ones where I have a bit more control on adjusting dosing and knowing how they function, and put him on a really low dose and observe. If his symptoms are going well, I might pull him off of the sucralfate first and observe how he feels. Then again, you can try coming off of the pantoprazole as well, but I would do it in a stepwise process for what it's worth. And again, that's all under the, I don't actually have his chart. I don't know everything for sure. But I haven't had a lot of great success with being able to say that I think the over the counters work the same or work well. Oh, uh, it's pretty, like Creon is pretty benign. I haven't met a lot of patients where if they kind of guessed wrong and took a little bit more than they actually needed, there's no major fallout. I do think, like, if I have a patient who has had their Whipple and they finished their chemotherapy with us and they're transitioning back to kind of being off of treatment and whatnot, sometimes if you really do not need enzymes and you keep taking them, sometimes patients start to get gas from them. But let's say you're identified as somebody who needs these enzymes. And like you said, there's a situation where you take them thinking you're about to eat and something comes up and you don't. No, there's no major fallout. It should not cause irritation. There's no kind of, maybe you make a bit more stool. I don't think so, though, if you're not eating with it. So there's no obvious, which is why we often advise patients to err on the side of caution and dose up versus underdose, because there isn't a known real risk. So the one thing I would check for, if your stomach has been removed, then you need a non-enteric version because you do not have stomach acid to break the coating down. And so Creon brand does make a non-enteric version. It's not used much in Canada. So I would really suggest that you speak with a pharmacist or speak with your doctor about a formulation that's not enterically coated. Because I feel like if you're taking the Creon 10s, they're coated for gastric acid and you don't have gastric acid. And so the other thing is asking the pharmacist to contact Creon and ask them, is there something like, could you put it in apple juice? And does that allow the coating to start dissolving so that by the time you're ingesting it, it's more functional? I haven't dabbled with that because when I have a patient who's had a gastrectomy, I use non-enterically non-enterically coated. And so I would just say, first and foremost, make sure that in your country there isn't a version that has non-enterically coated. And if there isn't, asking the company like Creon, going on their website and asking them, is there a way we can dissolve the coating if I don't have a different version available to me, to troubleshoot that? Because I would suspect if you've had a gastrectomy and you're trying to use these, they're not going to be working well because you're not dissolving the coating adequately.
Right.
No, other than it being annoying for you, probably. No, because it's the exact same beads. So the Creon 10 capsule is just a little bit smaller than the 25 and the 25 bigger. So one thing though, that because there's shortages quite a bit right now with Creon, I'm having it here in Alberta as well. And I do have to say, I get really frustrated that the pharmacist doesn't troubleshoot this better for you guys. But the reality is, a direct kind of exchange for you would have been Codazyme ECS 20, which I am not finding shorted right now. So my patients that are on Creon 25 and it's on a shortage right now, I'm having them switch to Codazyme ECS 20. If you already have the 10s, absolutely nothing wrong with it. It's just then, just like the number reflects, So you could take your current dosing of like however many pills times 25. When you were taking your 25s, take, if I was taking 3 times 25, that's 75, and I divide it by 10. So that's 7.5 tens would be equivalent to my 3 25s, and I would just round up and take 8.
That's
You
what
could
I've
try
been
taking
doing.
7 and see if you were symptomatic. But so is there anything wrong with it? Absolutely not. Just the annoyance of you needing to take that many pills, but they function exactly the same. They just have less of those microspheres on the inside of the capsule, so you have to take more of them.
Mhm.
But if that's
Now,
frustrating for you, I would get them to switch you on to Codazyme ECS20 because it's a direct exchange, like in
perfect.
dosing. So again, like I agree, I hear that. I think it's so that it doesn't get held up along the esophagus and cause any sort of irritation or held up in the stomach. So I find like if somebody is sitting with their food and their like snack or whatever in front of them, they take their dose of enzymes, take water to clear it and begin their meal. I've never, so I've never given my patients like you need to have 16 ounces or like I've never heard of in all the research or anything that I've done a specific volume amount, but I think it has to do with ensuring that it doesn't end up getting stuck and sitting, is my sense of it, and that it clears all the way through where it starts dissolving the coating at the right spot in your digestive, like in your stomach. So I
Perfect.
wouldn't get too hung up on like an excessive amount because I've had patients say that they're like, I have to take 8 pills and all this water. I don't even feel like eating by the time I'm done. And so I think it's not a specific volume and it shouldn't be excessive. If it was a partial surgery like a Whipple or a distal versus a whole, if it's a
Okay.
whole, you'll need them forever.
Yeah.
But partials, yeah, there's a decent amount of you that no longer need them long term. So usually as somebody's finishing treatment, one of the exit teachings I do is to talk with like, what are signs that I don't need them anymore? And so
Mhm.
usually what I'll look for is, do you ever forget to take them? So if a patient ever forgets to take them and feels no symptoms, zero side effect, that's a pretty good clue you don't need them. Because usually, if you need them, you feel awful if you forget them. So
Mhm.
sometimes, if somebody's going along and they're like, oh gosh, you know what? I really do forget them sometimes. I have you, whatever your dose is at, reduce by 1 at each of your meals and snacks and observe for symptoms. If no
Okay.
symptoms, reduce again by 1, And so sometimes it's that we can get patients down to requiring less.
Mm.
Sometimes we can get you down off of them. The other thing that I watch for, let's say you're like, no, I'm really good. I don't forget to take them. Then sometimes what patients describe to me is they're like, I don't know, Jessica, I actually feel like I get gas when I take them. So the other description when they no longer need them is that they actually feel like taking them initiates gas. And so
Uh-huh.
then again, to test the waters, we pull back the dose and observe. Do you get symptoms or not? Yep. Hemoglobin A1C is a great kind of 3-month average assessment of how your blood sugar control is. It's still excellent. There's no impact by the chemotherapy. The 2 regimes I referenced fulfirinox during the talk. The other main regime is your gemcitabine nab-paclitaxel or Abraxane. That's the other big common regime used in pancreatic patients. There's a couple others, but those are the 2 big guys. And your nab-paclitaxel or gemabraxane, it really doesn't impact blood sugar as much because you do not require, for the most part, dexamethasone, the steroid. And those chemotherapy agents aren't administered with a glucose solution. They're administered with saline in the IV bag. And so just so that you guys know, if you're on gem Abraxane, you're far less likely to have exacerbation of blood sugars versus the fulfirinox. Okay, so yeah, so quickly, the description I'll see from patients is there's not definitive symptoms that are obvious, but what I hear from patients is this sense of when they take them and they no longer need them, when they take them, they actually feel like they get gassy. So they hadn't been gassy for a long time, and now they're done their chemotherapy or their Whipple was years ago, and now they find they get gassy. I find instead of waiting for that, any of my Whipple patients or my surgical patients that are done treatment, I usually ask the question of, do you ever miss a dose? If you miss a dose and feel no symptoms or little to none, then I have you try tapering your dose downward and observing for symptoms. If you have not ever missed a dose and that's not the case, if you want to know if you need them or not, reduce your dose or omit a dose. Don't take it once and you'll know. If you reduce your dose and feel absolutely no gas, bloaty, gurgle, oily, urgent stools, absolutely no symptoms, then reduce them again and taper your dose down until you become symptomatic or until you discontinue the medication without symptoms, which tells you you do not need them. The alternative is just miss it, a dosing for an entire meal and observe. Kind of good question. It just depends how frequently you're stooling. And so if a patient is stooling kind of the enzymes are in a pretty good place, and so you're maybe having only 1 or 2 big soft form stools a day, if you kind of went out, like Deepak mentioned, you went out and you didn't dose up, usually it causes urgent stool within, I would say, kind of 4 hours-ish. Within the next few hours, somebody gets gas, bloaty, gurgle. But because there's so many factors that can delay the rate at which I'm having a bowel movement, be it pain medication, So what I would say is usually, as long as your bowels are moving every day, you should see the impact the day of or by the next morning. And, it depends, but usually you're eating fairly normally, except a one-off here and there, like you went out last night or whatever. If you're traveling and everything is a one-off because you're eating out of the home, then anything, but I would say we would expect to see things within that day that you misdosed or by the next morning. I don't find it does, but that may be where sometimes what can happen, and again, because I don't know you for sure and I can't see your scan and know for certain, what I see a lot for many pancreatic patients, because of where your pancreas is tucked right behind your stomach, what can happen is there can be a bit of a compression or a narrowing there. And fibers can kind of get hung up and delay stuff moving out of the stomach or through the area. And that can feel like bloating. It is bloating. It's bloating in my stomach, not bloating in my bowel. And so usually when a patient describes that they eat something and then they get this bloating, like if you were with me in clinic, I would have you put your hand over the area. If the area is kind of just under your sternum in your rib cage area, up higher above your belly button, then that's more about your stomach having a delay in the emptying, I would suspect. And I would wonder if you pulled some of the skins and seeds, if you felt better. I think though, if you troubleshoot it already by adjusting your dose, fair enough, if that's working and you don't have to, but I've not ever heard of fiber in my foods. Fruit and vegetable fibers are like fibers, insoluble, soluble, impacted by pancreatic enzyme dosing. It's more so, I think, mechanical in patients when I'm working with them. I'll try to remember the three. I think there's 3 questions. So first question, does taking too much make your stool hard? No. So creon themselves or coenzyme, pancreatic enzymes do not cause constipation, but they cause an increase in stool production. So if you have other factors that like predispose you to constipation, once we treat your malabsorption, the risk of constipation will present. So sometimes people are going along and they're like, I'm on hydromorphone and I am not constipated, Jess. Like, well, as soon as I treat your enzyme insufficiency and stop the malabsorption, constipation presents. So it's not creon or an excessive dose of creon that causes it. It's just the nature of then you not malabsorbing. And then whatever the culprit of your constipation is presents. So if you have constipation while you're taking enzymes, it does not mean it's from them or that you took too much. That's not the indication. So then the other part of the question, well, yeah, and so I would say that would be what I would advise you to try for sure. So
Okay.
for the most part, beef, whatever form of beef you're consuming, it is a much fattier meat than chicken. And so more often than not, I would expect that to be the culprit versus something else. So if you used to be able to eat beef and now in the context of everything going on, you struggle, but the first time you have it, have a tender preparation. So, but I would start by dosing up, have a tender preparation, don't have a massive 8-ounce steak, and just see how your body feels. But there's no kind of correlation with, oh, if you have pancreatic, then you can't eat beef. It's usually about enzymes.
I will be sending a follow-up email, so if there's any more questions, just reply to that and we'll try to steal a few more minutes of Jessica's brain offline. But yeah, just to let you know, Jessica, there's a lot of positive feedback in the chat, and everyone seems to have really appreciated this talk and found it really informative. So thank you so much for joining us today and for all of the really useful information.